proximal humerus fractures, complex fractures. So there are some tips which we must know what matters and a simple review of the plates. So just going to the basic, there are 4 anatomic parts which will decide your outcome. So greater tuberosity, which will migrate the fragment proximally and posteriorly. Humeral head, if it is fractured, it will lead to avascular necrosis. Surgical neck shaft, which will be pulled by pectoralis on the medial and superior side, and lesser tuberosity, which will pull it medial and inferior. So about vascular supply, there are 2 circumflex arteries which are going anterior and posterior, and this arcuate artery is a branch of that, and a damage to it may lead to avascular necrosis. So about humeral head vascularity, the arcuate artery is generally interrupted. But a recent anatomic study published in 2000 reiterates that perfusion from posterior circumflex vessels alone may be adequate for head survival. That's why if the BMD is good, fixation is still justified. Things to look before planning: what are the chances of this humeral head going into avascular necrosis, and about the bone quality. That is also important to know. So predictors of ischemia are the loss of integrity of medial hinge more than 2 millimeter and fracture pattern. Let's see on the X-ray. So this is a simple X-ray which is slightly displaced. So be aware of the lateral displacement of the head, because that will interrupt your blood supply. Metaphyseal head extension, if it is less than 8 millimeter, it is going to disrupt your blood supply. Blood supply is potentially torn if medial hinge is displaced, and this head is not viable. So before starting fixation, you know that there is a potential chance of avascular necrosis. Now let's see this X-ray. This is a complex looking fracture, but let's see the pattern. Medial hinge is not displaced. Metaphyseal head extension is more than 8 millimeter. So this head is viable. So if the bone quality is good, you are justified in doing a good fixation. So this study in 2008, which was a follow-up study to Hartel, it says that 80% of patients with ischemic head did not collapse. So fixation is worth considering even if signs of ischemia are there. Now about the bone quality. So how to assess the bone quality? We measure the diameter in anteroposterior and lateral X-ray. We take the cortical thickness at 2 levels at 2 centimeter apart, and we divide by 4. A mean cortical thickness of less than 4 millimeter is highly indicative of low bone mass density, which can lead to failure of fixation. So it's better to go for replacement in such cases. Reduction maneuver, just simple surgical neck, flexion, adduction, traction, and anterior pressure. And for greater tuberosity, since it is posteriorly, you lift it anteriorly and inferiorly. So and the surgical techniques, the 3 structures which are very important to identify, and all in relation to long head of biceps. The tuberosity, you should hold it well and rein the horse. Now, if you are going the approach, you should know this also. You should go between the watershed area of deltoid, anterior and middle level. It is more or less in the line of the acromioclavicular joint. How far distally you should go? Now, this is a study, cadaveric study, which showed that axillary nerve in relation to in neutral position, it is 6 millimeters from the AC joint. In adduction, it is 6.2 centimeter, and in 90-degree abduction, it is just 4.5 centimeter away. So be aware of this condition. So your position is also very important if you are going through this approach. Now how to simple suturing technique. So it should not be at the bony level. It should be at the attachment of the tendon, because the Sarpis fibers where they insert on through the bone, that is the strongest area. So you should hook it there. Now just to clarify the predictors of loss of fixation, varus should not be acceptable. The screw should be in all the quadrants of the head and as far as possible up to the articular surface. Now, does the function really improve if initial varus is addressed well? Yes, a constant score of 86 patient according to this article, and they also advocate liberal use of allograft. Philos recommendation: plate should be 8 millimeter distal to the greater tubercle. Screw should be 5 to 8 millimeter below the articular surface of humerus. Calcar screw within 5 millimeter of calcar. there should be 4 to 6 screws in the head, and shaft there should be 3. Plates should be placed 0.5 millimeter lateral to the lateral ridge of the bicipital groove, and avoid varus. If you think there is a collapse, you should use a allograft. Now just about this simple different types of plate. Now diffuse synthesis Philos plate, there are 9 locking screw options. In the upper row, they are parallel and cranial. In the B, they are converging and horizontal. It is not shown here. In the row C, they are diverging and cranial. In row D, they are 20-degree cranial. And row E, divergent calcar screw at 45-degree. Now let's see this Arthrex peak plate. They are polyaxial screw. They are liberal with plate position. You can change the direction. It is biomechanically and biocompatible better. There are no chances of metallosis, and there are lesser chances of screw penetration. Translucent plate, so better assessment of union by X-ray, and there are no chances of cold building. Modulus of elasticity is same as the cortical bone. Inert properties also reduce tissue adhesions. Disadvantage, 6 screws only proximally, no lag screw, biconvex head, microfractures are known to occur during insertion. Now let's see this Smith and Nephew plates. Advantage, there are 2 different systems with 3.5 locking option and 4.5. It is plano-convex, anteriorly curved plate shaft. It reduces your insertion, erasing the deltoid insertion. And it is side specific, so you have different for the right and left. Cortical and locking option in all the holes. Disadvantage, only 6 to 5 screws. There is no polyaxial screw and no spreading of the screws. Most screws go anteriorly and posteromedial bone is not taken care of. Zimmer plate, advantage, it is low profile, concavo-convex, anatomically contoured. Lag screw is cannulated cortical, and this is most important is self-drilling. So in osteoporotic bone, you needn't drill it, which causes loss of bone. Disadvantage, proximally only 5 screw, no spreading of screws, and most of them get concentrated at center. And they are not polyaxial screw. This is just a jest, cost-wise, and this is diagram showing all the different types of plates. Thank you.